we prepared a very difficult CTO case. For this case, we invited really eminent experts in CTO intervention. Dr. Please explain your institute and name.
I am Dr. Sakura. Thank you very much for your invitation. It's my great honor for me.
Okay. My co-operator is Dr. J.Q. Han and fellow Gong. Let me introduce our case. Slide, please. Okay. Next, please. 우리 화면을 슬라이드로 okay. This 45 years old male. Chief complaint is effort angina since several months ago. He actually underwent PCI last year in another hospital. At first trial, the RSA CTO failed, and second trial also failed 5 months ago. Thus, he was referred to our SNU hospital. Please, next. No remarkable finding in chest X-ray. Next. ECG shows a T-wave inversion inferorectal lead. Next. Echocardiograph shows normal wall motion. Next. Systemic SPECT shows reversible perfusion defect in mid-basal inferior basal inferoseptal wall. Next. This is outside CT angiograph. Shows the long CTO from mid part to distal. Next. Another reconstructed image of CT angio, calcified lesion. There is a spotted calcium along the CTO segment. That may be a guide for the true pathway of RCA plus. This is a coronary angiogram taken several months ago, 5 months ago, in another hospital. We can see blunt stump at proximal CTO segment. We can see the first island and second island. Thus, we can see the CTO segments are divided into 3 plus. Long CTO segment, but the first island or second island may guide us for the right direction. Plus, 5 months ago, other doctor tried to penetrate the long CTO segment through anterograde approach, but at the left panel, he missed first island, and right panel, he missed second island. Plus, then he chose one of 2 eminent septal branches, second septal branch. We can see the tip injection image. Plus, this is the image that we have taken. The second septal branch is very good, but it is connected to the small Pierre branch that is in the midst of third CTO segment, as shown in the right panel. Plus, he tried this approach, but struck at third CTO segment. Plus, and he once again tried the retrograde approach through first septal branch. It looks good, but the draining site is unclear here. The final connection tortuosity is not good. It's very acute for several times. Plus, and tip injection will demonstrate the acute tortuosity at the last part of collateral branch. He finally failed because of, I don't know the reason, plus. So this is the evaluation image in our SNU hospital. We can still see the 3 separate CTO segments intervened by 2 islands. That may be guidance to us. And we still see the first and second septal branch. Plus, this is selective LAD angiography. More clearly see the first and second septal branch. That is eminent. Size is good, but the draining side is not good for second septal branch. Dr. Asakusa considered the third or fourth diagonal branch, but that is not clear in the final connection point. Plus, how about the discussion point? First, let's focus on the antegrade approach. Unfavorable effect, phenomenon is shown here, blunt edge with 2 side branch. But the vessel is very big, so we can penetrate it with certain kind of guide wire. Plus, long CTO segment. But there's luckily 2 islands that may mark the right position of mid or distal RCA. Plus, I also consider retrograde approach because CTO segment is too long. Which septal branch do we have to use? First septal, second septal, or third septal, Dr. Asakusa recommended. This is the key to success. Plus, and let me show you the image that we taken just a minute ago. Angel, please. So this is a RAO, simple RAO image of left coronary arteriography. There are multiple collaterals from left to PL branches. First septal, second septal, and third septal. Plus, this is arteriocaudal image. Second septal is more prominent, but it drains into the bed. Thus, I like to choose first septal. Plus, this is bilateral injection. We can see the long RCA CTO segment. First CTO, then first island, second CTO, second island, third CTO, and PL branches. Plus, this is RAO view of RCA. We can see the first CTO segment a little bit straightforward. Plus, then I try to use both direction, retro and antegrade approach. Then I try to first select first septal retrograde approach, but it is from the stented segment. It's not so easy to engage the wire. Plus, with various kinds of maneuver, I put the wire into the first septal, like this, plus an advanced wire into the far distal, as shown here. Route is acceptable, as we can see the reference image. Plus, then I advance the catable microcatheter, plus, but bilateral injection, how do you think about? The branch is drained to the upstream of third CTO segment, right? Here.
Any comment?
How do you think about we we are going to land on the true far distal PL branch, but at this point, the wire enters a kind of PDA, a more proximal PL branch. Thus, it is not helpful to penetrate the third CTO segment. Plus, then I withdraw the wire and once again tip injection through the first septal branch. And there is a subtle image on the left side. Most left side branch leads to the a kind of connection to the PL branch. So from now on, I'd like to navigate my little wire into the subtle left side branch, into the subtle draining vessels into true PL branch. So is there a comment, a question?
Dr. Kim, could you show us the
Is there
prior?
any suggestion?
Could you show us the prior shot once again, where you had the wire at the distal area? Could someone just show us the prior cine?
Just PDA.
Yes, one of the
Yes,
branch.
I think so.
Just advanced catheter and check the final draining course. Okay, RAO. I'd like to advance the microcatheter. It's very difficult.
But I think it
Course
looks very difficult
is,
to use this guide wire for retrograde approach. So just now I confirmed from circumflex there is a promising collateral to PL distal, I think.
Does anyone want to comment on the
There is
different?
resistance here.
Which microcatheter are you using there?
This is Carabel.
Catabel. Resistance here.
Is the
Even
prof?
though I use 8 French guiding test, deeply inserted,
Is the profile
No,
of this
that's-
microcatheter
okay.
similar to the Turnpike LP, or is this the go-to microcatheter for you
do I
guys
have
here?
to change
Yes,
to
yes.
Corsair?
This is
Yeah, Corsair.
Japanese,
kind
as I
of.
think, in the company,
Okay.
microcatheter is very slippery
당연히
and
틀어줘, 그럼.
tapered, very excellent one.
It's different vessel.
Can you tell us
This
which?
is Corsair Pro. The penetration force is significantly better than Catabel. Yeah, we can reach the PL branch here. Dye injection.
Which wire did you have in there? Can you tell us which wire you had in there, Dr. Kim?
I removed the wire, field the FC. FC means fine control. This does not help to localize.
PD branch.
Oh, yeah, PD. 자, epicranial or areocranial. It's good. Then we redirect the wire into the distal stump of the third CTO segment. All right, epicranial 또는 areocranial. Can you see the image? Okay.
This is very good sign.
자.
There is connection to the
별로 하지도 않았는데.
PL branch. So,
We should go left
Yeah,
side.
yeah, left side.
yes, yes.
Soft wire, another one.
필드 F 다시 F 1번 한번 주세요. 필드 F.
after I put the wire into distal stump, then I start antegrade approach. 그대로 놔두세요. It's very difficult to
Yes.
put the wire on the left side because of the tortuosity. Back up more, but I'm not sure Crusade can pass such as.
Maybe in this situation, I will.
I'm going to pass the wire first, the far distal PL, then advance the corsair into the true PL main branch, and then start the peaking of the distal stump. 이게 힘 못 받네. Yeah, prolapsed.
Yes. Yes.
Anatomic morphology is very bad. It is
More
possible
promising.
for this until this maneuver, but further manipulation may cause the prolapse of wire into the right side, not
yes.
further increase advance into the left side. Probably difficult. Circumflex, PL. Do you want to see this picture?
From guiding.
no.
Guiding
Minus
catheter
four.
injection.
Okay, minus.
Maybe yes.
This
yes.
picture?
Can you see? Right
Okay,
side. Right
you
side.
can see there's
Yeah.
circumflex to. Okay. Upon your recommendation, I changed the septal collateral branches from septal to the circumflex to PL branch. Minus.
Yes. Yes.
Let me check the branch, the other angle, minus. Okay, minus. Okay, 아래요. I'd like to remove
Dr. Kim,
collateral from first septal because acute angle it is impossible to reach the final destination. This, with the advice of Igarashi, I switched the septal retrograde approach from septal to
Yes.
circumflex epicardial collaterals. Here's a areocaudal view to see the feeding vessels from circ. You can see the three tortuous vessels. Among them, the center vessel supply the collaterals to PL branching.
Okay.
Next, please. This is tip injection showing the right and middle part of three branches. The middle part is the supplier plus, and advanced to the middle part, and then we can see right part is the right direction plus. Cranial view can clearly see the collateral channels plus. And it takes time to struggle the tortuous small vessels here plus. Then finally, able to pass the true channels with XTR. Here,
Okay.
plus. Then we took a angiogram to confirm these channels drain into far distal true PL branching.
Yes. Yes. Yes.
Plus, the problem is it is difficult to advance the corsair. So we switched the newer corsair that can pass through the most angulated segment. But still, it is very difficult to advance more. In other words, we took anchor balloon technique at proximal LAD, stented segment with 3.5 balloon, and then changed the corsair with newer one. Then able to pass through the corsair into the draining PL branch plus. This is angiogram to confirm the corsair is in the PL branch, and I switch to the stiff wire at this point to puncture the distal stump from Gaia first, second, and Concast Pro. But distal cavity is too hard. Plus, it's very difficult to puncture the distal cap. Third CTO segment is very hard. Plus, this is tip injection. Plus, this is the Concast Pro. It's very hard. Thus, I just made a knuckle
Yes. Yes.
and push it until at this point, and then I switch to antegrade approach from now on. This is the progress that we achieved for the several minutes. Okay. Then I approach to the proximal stump of mid-RC CTO with soft wire and corsair backup, LAO. Wire tip is at the proximal stump of CTO segment. Then I'd like to pass the wire into the first island.
What wire are you using?
Gaia second, used in the left side. It goes backside. 5 months ago, the wire passed in backside the first island. It is impossible to manage the direction. The backside island, 5 months ago, the same. Because of calcification in true lumen side, okay, because time saving, I just passed through intima here, LAO. Guiding is backup support is weak, thus I cannot
Yes, I agree.
advance
So,
easily.
It looks like you've made some progress, though. Is that an 8 French AL.75 guide that you have, or a 7 French?
This is 7 French. Left side is 8 French.
this
A little bit progressed.
Yes.
Okay, I advanced the corsair into the first CTO segment, if it's possible. Okay, possible. Then get a stronger backup. The guiding catheter is pushed backward.
Yes. Yes.
It's impossible to advance further.
I didn't see any.
Until the time limit, I tried to advance Gaia as far as possible. Then after transmission, we may change the guiding catheter stronger one.
Yes. Yes.
Yeah, there is a side branch as the ostium of RCA. We can use it, or at the side branch at the proximal ostium, soft wire. As your recommendation, we can use anchor ballooning, soft wire. Okay, the procedure should kept on, and then final results will be presented at the end of 4th live case, TAVI with Sapien 3.
Okay, good luck.